Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training.
Good afternoon. It depends on where you're calling from. Thank you so much for joining us in the fourth of our dental webinar series. Today we have a tag team of maxillofacial prosthodontists who will be lecturing us today. So we're going to start with Dr. Kim. Dr. Kim is a maxillofacial prosthodontist. She had DMD, Doctor of Dental Medicine from the Harvard School of Dental Medicine. And she also had, I believe, a prosthodontic training at the University of Illinois in Chicago. She was into private practice in California, and she had maxillofacial training, I believe, in UCLA. Am I correct? Okay, so you'll correct me as we go along. She's currently a clinical assistant professor at the University of Illinois in Chicago. She holds a certificate in advanced prosthodontics, a certificate in maxillofacial prosthodontics, she's a diplomate of the American Board of Prosthodontics, a fellow of the American College of Prosthodontists, a associate fellow of our American Academy of Maxillofacial Prosthetics, and a member of the American Dental Education Association. Dr. Kim, thank you so much for your willingness to teach us today. The floor is yours.
Hello, everyone. Thank you for having me. And I will go ahead and share my screen. Today, I would like to introduce you to maxillofacial prosthetics. Maxillofacial prosthesis replaces missing structures and functions for those who have developmental or acquired defects in the head and neck region. Due to the fact that these defects are visible or noticeable socially, a lot of these patients tend to retract from society, and therefore they don't get the funding or the support that they need. Within the United States, there's 5 fellowship training programs, and some countries do not have any such training programs. So my goal is to increase awareness and interest in the field of maxillofacial prosthetics so that we may improve the access to care for these patients. Many of these patients will present with the cancerous condition, and with the surgery, they also may receive radiation therapy. So I will also cover the necessities of pre-radiation dental consultation that we may help with improving the quality of life for these patients after survival. So here is one of my patients. He presents with squamous cell carcinoma of the maxillary ridge, as you see in his upper left. He had already met with all his doctors, surgeons, and radiation oncologists with the final treatment plan that he would receive a surgical resection, radiation, and chemotherapy due to the fact that the disease was quite advanced. So the surgeon will ask for an immediate surgical obturator to be fabricated, but also we need to perform a pre-radiation dental consultation and perform any immediate dental treatment before radiation therapy is initiated. The purpose of the pre-radiation dental consultation first is to inform the patient of the radiation-related complications, especially that relates to the oral cavity. Many times these effects are not closely explained for the patient, so as a dental provider, you want to establish realistic expectations for the patient. Then is to examine the dentition, not only just to treat active disease, but to determine which teeth will need to be removed to prevent future risk for osteoradionecrosis. The last is also to inform the patient how their dental care will be different after radiation therapy is complete. Before the pre-radiation dental consultation, it is absolutely necessary to speak with the radiation oncologist and the surgeon to discuss the treatment plan, because the treatment plan will determine what your pre-radiation dental treatment would be and how you would fabricate immediate surgical obturator. The oral radiation effects that must be discussed first is oral mucositis. Although severe in form, thankfully this is an acute side effect, usually starts about 2 weeks after radiation therapy starts, and it resolves within 4 weeks or so after radiation is complete. It presents in the form of inflamed gums, painful ulceration or sores that may result in difficulty eating and also using a dental prosthesis if patient has an existing one. Next is dry mouth due to radiation of the salivary glands. This is a long-term side effect with little improvement. Dry mouth is treated with just short-term symptomatic relief by drinking a lot of water or liquids, using lozenges, or also patients can choose xylitol gum. But again, these are just symptomatic short-term relief. We worry about the secondary effects of dry mouth, which is increased risk for active dental disease such as caries and periodontal disease due to the fact that, so we want to emphasize that patients must have superb oral hygiene to prevent future dental diseases. Another side effect is decreased altered test sensations, and this may be a semi-permanent or a permanent side effect and depends on the radiation dose and the patient. The last two complications I want to emphasize, due to the fact that they're long-term side effects and they present much later after radiation therapy is complete, these side effects are forgotten to be mentioned. And now with patients surviving for longer, they may live up to the point where these side effects become symptomatic. When an area is radiated, scar tissue starts to form, and the scar tissue will continue to worsen over time. So we must recommend that patient engage in mouth opening exercises. And that's basically holding their lower jaw down. I give the patient 777, an easy number to remember. So that means patients will have to perform these exercises 7 days a week, every day, 7 times a day. So spread throughout the day ideally. And they're holding their lower jaw down for 7 seconds. This is the minimum number of exercises they should be performing. I tell the patients the more you do it, you're delaying the progression of scar tissue formation for it to become symptomatic. As you see on the upper left here, this patient was never informed of performing such stretching exercises, and he presents to me with this as his maximum mouth opening. You can imagine how this will affect his quality of life, nor can he perform any oral hygiene exercises. Another device to improve compliance is dynamic bite openers, as you see on the upper right. We can ask patients to use tongue blades, but with the dynamic bite opener, such as the TheraBite or Oral Stretch, you can improve compliance because it's much more easier for patients to perform these exercises. Along with the fibrosis, scar tissue formation around the mouth, scar tissue can also form in the neck muscles and the soft palate region if that area is radiated. And this, again, will continue to worsen over time. And when it becomes symptomatic, it results in difficulty swallowing and speaking because patients are not able to achieve velopharyngeal closure. And you can imagine how this would affect their quality of life and also their health. These symptoms will appear more than 10 years later, so it's very important that patients perform these exercises and you remind them that although they don't see the effect of the exercises, that they are delaying the rate of progression of this from happening. Some of the exercises that help that may delay the process of this is singing in falsetto, holding the mid-swallow, so our throat muscles, soft palate muscles will go up and then down during swallowing, and holding that mid-swallow when your palate muscles go up. And also holding a ball with your neck, small ball, a tennis ball. You can use the side of your necks as well. So these exercises just overuse these muscles. And again, the idea is that you're trying to delay the progression. The scar tissue formation will happen, but you're delaying the progression of it. Now back to the pre-radiation examination. The examination is similar to any comprehensive examination we would perform, but you, again, would have communicated with the radiation oncologist to see where the radiation will be given and how much of the dose. And this will determine your approach in terms of therapy before radiation. I want to add on to the comprehensive exam. For the extraoral examination, it is helpful to record the patient's maximum opening and the range of motions. That way you have a baseline to compare when patients presents after radiation. So during the pre-radiation examination, we want to extract teeth with the questionable prognosis. And these teeth, examples of these questionable prognosis are dense carious lesions, periapical infection, significant periodontal disease, and we have an aggressive extraction policy for mandibular molars due to the fact that majority of osteoradionecrosis happens in the lower posterior area. So this means that all class 2 and 3 furcation defects will have to be extracted. For the maxillary teeth, we can take a more conservative approach because the maxilla is more vascular. It can actually have a higher tolerance for radiation before the bone healing capacity is compromised. Not just with the maxillary mandibular, but there's also other factors that affect whether your approach for extraction will be conservative or aggressive before the radiation therapy. Patient's dental compliance, motivation, and physical ability will determine whether you would be more aggressive or not. If patient initially presents with poor oral hygiene, you may take a more aggressive approach because it's very difficult to change one's habits. Also, the urgency of radiation will determine treatment. You need at least 10 to 14 days for the extraction socket, the soft tissue to completely heal. And a lot of times, in order to reduce the osteoradionecrosis risk to 0, you have to wait 25 days. But many times these patients have urgent need for radiation treatment and will not be able to delay their radiation treatment for their dental therapy to be complete. If patient is receiving simultaneous chemotherapy, we add on about 10 grays to the radiation dose. So high dose, if patient is receiving more than 65 grays in an area, you would extract the teeth, take a more aggressive approach. If patient is receiving intermediate dose, which is around 55 to 65 grays, then you would determine whether to take an aggressive or conservative approach by the factors presented here. In low dose patients, you may be able to be more conservative and preserve the teeth. Another factor that determines the approach is the prognosis of tumor control. If patient has significantly advanced disease and receiving therapy more for palliative reasons, not necessarily to treat the disease, then you may take a more conservative approach and leave the teeth in so patients can enjoy the remaining quality of life with their teeth and function. Pre-radiation extraction should be atraumatic, and this means that multi-rooted teeth may have to be removed in segments. The most important thing I want to emphasize is the need for radical alveolectomy and smoothing sharp edges of extraction sockets. If patient presents in the following photo scenario on the upper right with irregular ridge anatomy, patients will not be able to tolerate any dental prosthesis. Due to the fact that this area is heavily radiated, patients' tissues are fragile. And if you have a prosthesis on top of irregular ridge anatomy like this, it'll result in bony exposure and also ulcers for the patient. Patients, due to the fact that they have received radiation, they would not be even able to get implants or an alveolectomy. So at that point, patients cannot have any kind of prosthetic rehabilitations. So in order to prevent that scenario, you want to make sure you communicate with the surgeon the importance of radical alveolectomy at the time of pre-radiation extractions. So that means removing any irregularities, any sharp edges, or significant undercuts that will later prevent the use of a dental prosthesis. Extraction of bony or tissue-impacted mandibular third molars are not recommended unless there's direct communication with the oral cavity. Because if these are extracted, patients will need at least 3 weeks of healing time, and often the urgency of radiation treatment cannot wait that long. For partially erupted third molars, we recommend extractions due to the fact that there's significant risk for pericoronitis, which may increase the risk for osteoarthritis. Be creative, so I included these bottom 2 radiographs here. This patient has a second molar that has advanced carious lesions and should have been extracted. But if we would have extracted the second molar, we worry about the third molar erupting. So what we did was do root canal therapy and decoronate the tooth. And this will prevent the third molar from erupting out to the oral cavity. After the examination and dental therapy before the radiation treatment, we also want to inform the patient again how their dental care will be different after radiation therapy is complete. So we want to remind them their risk for caries and osteoradionecrosis will persist indefinitely. And this means that patients should engage in more frequent recall and maintenance visits. Also, maintain superb oral hygiene. And we also want to tell them daily use of fluoride trays, and we would be making these fluoride trays for the patient. So fluoride trays are easy to make. You take an impression pour cast and you'll do a suck down of a fluoride tray material. Another use of these fluoride tray is during radiation therapy. It can prevent backscatter if patient has any kind of metal restorations in their mouth. After radiation therapy, you'll recommend using this fluoride tray for 5 minutes after cleaning their teeth and avoid rinsing for an hour afterwards. Now, back to our maxillofacial patient. We determined that all his teeth are salvageable except the root tip on the upper right, which was extracted before radiation therapy. And we also, the radiation therapist may ask for a radiation stent. So in order, on the left here, the radiation oncologist will make an extra oral radiation stent to position the patient's head in the same position during every radiation session. And as dental providers, they may instruct us to make an intraoral radiation stent. And usually they would ask that leave patient open about 20 to 25 millimeters. And either they'll have instructions on the middle upper photo here, the plate goes across the occlusal plane. So this is to leave the tongue below the occlusal plane. Another thing that I like to do is I have a little hole here. So then I would instruct the patient to leave their tongue under that hole during the radiation session. On the bottom here, the radiation oncologist actually asks that we move the tongue away from the left mandibular ridge as much as possible. So we use some hard reline material to push the tongue away and not necessarily below the occlusal plane. The surgeon would have communicated where the surgical resection would take place, as noted in this red line here. So I would extract all the teeth or grind off the teeth on the side of the resection, and also restore ideal contours of the palate and the ridge here. We would need to clasp as many teeth for retention of the obturator. And with cold cure ortho resin, you'll make an immediate surgical obturator, as you see on the bottom right here. Patient will present, as you see on the left here, after resection is complete. And you can see the large communication between his sinuses and his oral cavity. The immediate surgical obturator is screwed into the patient's remaining palate. So it actually is there when patient wakes up in the morning, and it helps them psychologically to not feel the defect when they awaken from anesthesia. Other benefits of the ISO is that it can increase in-hospitalizations due to the fact that it decreases the risk for nasogastric tube. It also restores the patient's speech and swallowing immediately after the surgery. And also it holds the packing, the surgical packing inside the patient's sinuses while the initial healing is taking place. Then back to you, and at this time you will have to reline the ISO to the defect area. And we like to use rim seal material, as you see on the lower right here, because it's less porous than soft reline material and has a long working time. After the healing site is healing is complete, usually takes about 3 to 8 months depending on the patient. You will notice this by you not having to reline the interim surgical obturator. And also patients should be mentally ready for a definitive obturator at this time. So the definitive obturator is made with a metal framework, just like a removable partial denture, but the only difference is you'll extend into the defect area, as you see on this right photo here. If patient partially edentulous, you will always do an ultracast impression to get a functional impression of the palate area, especially important when patient's movable soft palate is involved. So this is my patient, Charlie. He was diagnosed with osteosarcoma of the maxilla and has been a patient at UCLA. He is receiving his third prosthesis from me, and he talks about his experience having a obturator.
Hello, my name is Charlie Lustman. I am a singer, so not to be able to have what I need to be able to sing is pretty much the end of my high standard of living, which is doing something I love to do. So this as I was saying, I can't talk, I can't chew, I can't eat, I can't sing without this. So it's such an important part of my life, and it has been really important to me also to have a place to go that there is empathy as well. Hello, my name is Charlie.
So as you can see, a maxillofacial prosthetics can definitely improve a patient's life by restoring basic functions such as speech, swallowing. Here, I would talk briefly about mandibular diseases. When there's tumor, cancer, or osteoradionecrosis of the lower jaw, often the treatment is surgical resection of the lower jaw and reconstruction. Nowadays, reconstruction is done with a flap Flap actually harvests the hard tissue and the soft tissue with it. And this helps to keep the flap alive and also get the ideal quantity and quality of soft tissue as well. Fibula-free flaps are often used to reconstruct the mandible nowadays. Oftentimes, the surgeon may ask you to make an occlusal stent, as you see on the lower left here. And basically how you make this is just having cold cure resin in between teeth and have the patient bite down. This will help the surgeon to position the lower jaw after the resection to the patient's natural occlusion. Now we also have the help with digital technology. We can make a much better reconstruction that's ideal for the future prosthesis for the patient. And you can also place implants at the same time, already knowing where the future prosthesis will be located. This patient had squamous cell carcinoma of the mandible, and she had gone through a surgical resection and reconstruction with the fibula-free flap, but also had gone through a full course of radiation, had a recurrence, and had to go through another full course of radiation. So she has very fragile, friable tissue, as you can tell by these telangiectasias on her gum tissue here. Therefore, she can't get any kind of additional implant surgery or any extractions. So because one of these teeth were deemed unrestorable due to advanced carious disease, we performed a root canal here due to the fact that she has a large vertical defect and unfavorable anatomy from the flap ridge reconstruction. We want to keep those two teeth. Two teeth is better than no teeth to help with the retention and stability of the prosthesis. Hey, Max, as healthcare providers, we need to address the social injustice in healthcare along with providing care for our patients. I hope this presentation sparked your interest in maxillofacial prosthetics and how we can improve these patients' quality of life that are often forgotten because they retract from society as their defects are visibly and socially noticeable. If you want to learn more about maxillofacial prosthetics and other dental topics, ffofr.org is a website made by the UCLA folks, and it's free for everybody. And I highly recommend that you check it out. Thank you very much for your attention today, and I will take any questions.
All right. I'm going to run now. Thank you so much, Dr. Kim, for that very brief and very insightful presentation. I'm going to run a poll, and you would, go through the answers and take a couple questions. So, like before, if you've been here, I would get the poll started now. All right, I'm going to launch the poll, and it's going to run for 3 minutes. So just answer to the best of your ability. I'm going to have a post one. After we finish today, I'm going to send one to your email, but just answer as much as you can. Thank you. Can we all see the poll questions? If you can see, just go ahead and answer as much as you can. We're halfway there. The answers are coming. Just keep going. Thank you. All right, we are almost at 73%. Just going to wait for another 15 seconds here and we'll end the poll. All right, I'm going to end the poll, and Dr. Kim, can you please, I'm going to share the results. If you could go through the questions and the answers.
Okay, which of the following are examples of maxillofacial prosthetics? And we have 96% of the people, of the students and faculty picking obturator, which is correct. The others are prosthodontic, what we would say normal prosthodontic prosthesis. The second question, which of the following prosthesis is placed at the time of resection surgery? 70% of our participants answered correctly as the immediate surgical obturator. We often call it an ISO. The interim obturator is used during the healing phase of the resection area, usually 3 to 8 months, and this is when you would be adjusting and relining the obturator as the scar tissue contracts. The mandibular resection appliance is a maxillofacial prosthesis used for a mandible after a resection has been performed. And the definitive obturator is the last final permanent obturator you would make for the patient after their healing is complete. Number 3, which of the following is an acute side effect of radiation? So acute side effect meaning, I meant short term, so maybe it was confusing. Dry mouth does happen early. It could happen early, but not as early as oral mucositis, and dry mouth persists indefinitely. Versus the oral mucositis, it's an acute side effect, meaning it happens at the beginning, maybe 2 weeks after radiation is complete, and it resolves after radiation therapy is complete. So the correct answer was oral mucositis, but I understand this may have been confusing since dry mouth does happen early. But again, it persists. It's a long-term side effect. Fibrosis and trismus, as I had mentioned or emphasized, it's a long-term side effect. It happens much later on after radiation is complete. Number 4, which of the following is the purpose of pre-radiation dental examination? And yes, it was all of the above, to inform the patient of the radiation effects, especially how it affects their oral health, to inform the patient of dental treatment after radiation therapy and how their dental care will be different, to determine the questionable teeth to extract, because in order to prevent future risk for osteoradionecrosis, which is a very severe complication, and also to treat active dental disease before radiation therapy is initiated. Number 5, which functions can a maxillofacial prosthesis help to improve a patient's quality of life? There was a typo, so it should have been which functions can a maxillofacial not help with. So it actually would have been breathing, and everybody has selected speech, swallowing, and mastication. And yes, it helps with all those three functions. So everyone got it correct. Number 6, which of the following habits are useful for an irradiated patient to decrease complications of the radiation? And it was all of the above, and it's doing the daily mouth opening exercises, daily fluoride application, more frequent dental recall visits, and also maintaining excellent oral hygiene habits.
All right. We have a question here. Somebody says, I want to know the best approach for a patient who has had a total maxillectomy. How and where will the obturator be anchored?
So you would communicate with the surgeon if there's any ridge or palate that will remain. So you would use whatever structures that remain. If there's absolutely none, then for any resection areas, we highly recommend that we ask the surgeon to do a skin graft in the defect area lateral walls. So hopefully the skin graft is placed all around the lateral walls after the total maxillectomy. And once you place a skin graft, during the skin graft and mucosal junction, there'll be a scar band formation, and this will result in an undercut above the scar band that you can engage. So you can make an obturator engaging the soft tissue undercut above the scar band formation and any other soft tissue undercut that you might have after resection. And obviously these prostheses are going to have limited retention, stability, and even limited function, and you do have to speak to the patient about proper expectations.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator